So good afternoon, everyone. Thank you, KSOS, for this opportunity. From retinoscopy, let us jump directly into subjective refraction. So you have all heard Dr. Chandrasekhar telling you about how to do retinoscopy and how to derive the value from retinoscopy. You would have also seen that he has given you a prescription from the retinoscopy. So then what is the relevance of subjective refraction? Why do we need to do subjective refraction? Can't we just prescribe from what he has given there? No, because retinoscopy, especially when it's a wet retinoscopy, it is done under an artificial condition. That is not the condition in which the patient is going to live his life. So you have to give him that power and subjectively assess whether that patient accepts your retinoscopy power and whether you can give him the best corrected visual acuity doing some refinement. So that is why we need to do subjective refraction. You cannot give it just based on your objective assessment of his refraction, because people are people. Some accept less, some accept more. That is one problem. Second problem is that you have completely eliminated accommodation when you did a wet retinoscopy. So now here accommodation comes into play. So how much of the accommodation is he using? How much can he relax? All these things will decide what the subjective refraction is. So let us now jump straight into the topic. What is subjective refraction? It is a term applied to the technique of comparing one lens against the other using change in vision as the criteria to arrive at a dioptric lens combination that results in maximum visual acuity for the patient. So it is a subjective thing. So it is dependent on the patient. It is not like retinoscopy where you don't need much cooperation from the patient. It is sometimes not possible to do in uncooperative or retarded individuals. It may be altered by malingering and in poor or slow responders. Now, as we start, I'm going to give you practical tips about subjective refraction. The theory of it is like written in the textbook. So all of our steps are going to be practical steps. So the first step would be to make yourself and the patient comfortable. So introduce yourself to the patient. Take a quick history. Subjective refraction is just not giving the retinoscopy reading. So you need to know what the visual needs of the patient is, what is the occupation of the patient, at how much does he use his distant vision, how much does he use his near vision. You should know about his present glasses, whether he has any problems with his present glass or is he just comfortable with his present glasses. What is he using now? That is very important. Any treatment history, there are many drugs that can change, give myopic shifts, and any systemic diseases, any medications that he is using. And your first step will be to determine pinhole visual acuity. Since we have not had a class on refraction before, a small 2 tips on pinhole visual acuity. So pinhole, you know, eliminates all the peripheral rays and literally passes the rays through the principal axis so that there is no refraction taking place there. So that the patient gets the pinhole visual acuity tells you how much the patient will improve with refractive correction. If you eliminate his refractive error, how much will he improve? Now, when you do a pinhole visual acuity, please be sure that the pinhole is actually in front of the pupil of the patient. So you need to ask the patient and tell him that there is a hole there. You look through that hole and that is the chart you're supposed to see and then read. Sometimes they don't align, and then you'll find, especially CAM patients, their pinhole visual acuity will turn up to be less than what they actually read without the pinhole. So that is very important. The pinhole visual acuity in subjective refraction gives you an end point. It tells you when you can stop. Okay, this patient is going to improve only this much. There is no point in keeping on adding plus or taking off plus to make him read more. Now, where do we start? What do we put in the trial frame when we start subjective refraction? You can have many starting points. One is the retinoscopy value after cycloplegic refraction, which is what, like Dr. Chandrasekhar said, you have that value there. You can put that into the trial frame and start. If you're going to do a dry retinoscopy, which is a very easy thing to do if you are used to it, if you do a dry retinoscopy, you can have the reading of the dry retinoscopy itself. You can have your autorefractometer reading, which is what I think about 90% of people will do once they pass out. They take the autorefractometer reading and put it into the trial frame and start with that. You can start with PG power if the patient's already using glasses. And a rough estimate, if you don't have any of these things, you can start, just look at the visual acuity of the patient uncorrected. The denominator of the visual acuity divided by 18 will give you an approximate amount of refractive error that the patient has. So 6 by 36, 36 by 18, 2 diopters. Now, a small tip about dry retinoscopy. If you're doing retinoscopy without dilating the patient, you place the distance correction in the trial frame. So you do a trial retinoscopy with the trial frame in place. You place 1.5 diopters or 1 diopters in both sides, depending on whether you're doing it at 2/3 meters or 1 meter. That will fog the eye and it will prevent accommodation. And now you do your retinoscopy, preferably using the spherocylinder method. So you have both a sphere and the cylinder at the end of your retinoscopy. And now you remove the distance correction. What remains in your trial frame at the end of that dry retinoscopy is the subjective refraction of the patient, or your starting point of subjective refraction. And if your patient can read 612 or better with the lens in the trial frame after your retinoscopy, then half the battle is won. Now all you have to do is to refine it from 612 to 66 with your subjective refraction. Now, tips and tricks during the subjective refraction process, do be systematic so that you don't miss any step. Minimize errors because it is subjective. So you have to keep using checks that the patient is not fooling you. Do it at a fair speed so you don't tire out your patient. You don't keep saying, "Idano better, adano better, idano better," and you make the patient feel really confused. And speak clearly what you expect from them. What do you want them to see and what do you want them to reply? And be patient with your patients. Seat the patient at 6 meters from the Snellen chart. Place the trial frame, ensuring centration and comfort. You're going to be spending some time with him with that trial frame. So it shouldn't be poking in the wrong places. It shouldn't be tilted and all that. Place the appropriate correction in the frame and either occlude or fog the other eye. The best spherical correction is first determined. So the first step is to, after pinhole visual acuity, it is best spherical correction. Add the plus and make him read. Power depends on the visual acuity. If he is reading 612 or better, you can start with 0.25 increments. If the visual acuity is like 624, then you start with 0.5 increments, and better proceed with 0.25 increments, placing the next lens first before you remove the previous. If it is worse with plus, go in the opposite direction, add a minus 0.25 and see if he can read better. And stop when the visual acuity is 6.6. Once you're adding minus there, don't add more minus once the visual acuity reaches 6.6. Now, sometimes when it's a myopic patient there and you're keeping on adding minus 0.25, he will say better and better. Sometimes what happens is that the letters just get smaller and darker. So you have to ask the patient, is it just smaller and darker or is it really better? Better should mean better increase in visual acuity. So a 6.9 parts should become 6.9, 6.9 should become 6.6 parts. And it should not just be 6.6 parts, but I can see better, because myopes have a tendency to accept more minus than they require. And this should be consciously avoided. The final aim of a spherical refraction, subjective refraction, is to determine the minimum minus correction or the maximum plus correction that gives the best visual acuity. So if the patient reads 6.6 with the plus correction and you're giving him a 0.25 and he's still reading 6.6 and he says clear, you can give him that 0.25. If there is minus correction in the frame and he reads 6.6 and you give him a minus 0.25 and he says it is better, but he's not reading anything further, it is at 6.6 itself, then you don't give him that minus 0.25, you take it off. So minimum minus correction, maximum plus correction. Next step would be to determine astigmatism. Often there will already be a cylinder in the trial frame in your starting point. Sometimes there will not be, in which case you can use this instrument to find out if there is any element of astigmatism that you have missed out in your retinoscopy. You can use this instrument to find out what is the axis, to refine the axis and the power of the cylinder that is already there in the trial frame. And this instrument is called a Jackson's cross cylinder. It is an ingenious instrument in which there is a combination of two cylinders of equal strength of opposite sign placed with their axis at right angles to each other. The sphere is one half of the cylinder with opposite sign. That's how it is made. It is two cylinders. So this cylinder acts at this axis and the other cylinder acts at the other axis. And the handle is placed at an axis of 45 degrees. The most commonly used cross cylinders are the 0.25 and the 0.5. The red line or red dot denotes the minus cylinder action and white dot is the plus cylinder. 0.5 diopter cylinder is used when visual acuity is less than 612 and 0.25 when visual acuity is 6.9 or better. Just to have a look at that again, here you can see that these are the white dots. The white dot is the plus cylinder and the red line is your minus cylinder. And the handle you can see is set at 45 degrees. Now, how is it done? First, just to determine if the patient has any cylinder, you place it with axis at 90 and 180, and it is flipped. So you place it at with the axis at 180, and then you flip, means the minus axis that you gave at 180 will become now at 90, and reverse. So basically, you're just adding a cylinder in one axis and adding another cylinder in other axis when you're flipping. And that will tell you if the patient says the vision is the same in all positions, then the patient has only a sphere. If he says any position is better, that means that the patient has a cylinder and you need to add a cylinder. Now, let us assume that the patient already has a cylinder in the trial frame when you started off your subjective refraction. From your retinoscopy, you have got a cylinder there. In that case, you need to refine the axis of the cylinder first and then the power. This is because without the correct axis, you cannot determine the correct power. Now, with the best sphere in position, which we already did, ask the patient to look at one line above the best sphere acuity. So if he read 6.9 with his best sphere, you make him read 6.12. So that will give him the nuances of a cylinder correction will be better with that particular line, because the cross cylinder will blur vision slightly. Now keep the cross cylinder with the handle coinciding with the cylinder axis in the trial frame. If there is a minus cylinder in the frame, you look at the red line on the cross cylinder. So you know that the red line is the minus cylinder. So you look at the red line, but the handle should be aligned with the cylinder axis. So you have a cylinder axis at 180 sitting there. You have maybe a minus 0.5 at 180. You hold the cylinder, the cross cylinder, with the handle aligned. And then you look at the red line and you flip. And you determine which flip position is better. Is the red line to the left of your present axis, or is the red line to the right of the present axis? Is the patient saying the position is better? If one position is better, then you move the axis 10 degrees towards the preferred red line position. So you have a 180 degree and he said that this position is better, then you just move the cylinder in the trial frame 10 degrees towards that preferred red line position of your cross cylinder. So here that is what is being shown. You have a minus cylinder there and the cross cylinder axis is like this. So you're going to move the cross cylinder in this direction. Now you have to keep repeating this. So next time when you hold the cross cylinder, again the handle should be aligned with the new position of the cylinder, not again at 180. If you have kept it now at 170, then you have to align the handle with the 170 and then do both the flip positions. Now once you have determined whether the axis is correct, then you have to refine the power of the cylinder. Now, if you have reached the correct position, both flip positions will be equally clear or equally blurred. So you can tell the patient, is this position better, 1 or 2, or are they equally clear or equally blurred? If they are equally clear, then that is your axis. You don't have to move it any further. Next is to refine the power. Now, if you use the minus line, if it coincides with the axis of your cylinder, you are actually adding minus cylinder. And if the plus line coincides, you are decreasing the minus cylinder in your trial frame. So that is how you refine the power. So you use whichever flip position, first flip, second flip, which is better. When you added minus cylinder, if it is better, you add minus cylinder to the cylinder in the trial frame. When you took away minus cylinder, it was better, or when the white line was coinciding, it was better, then you give him a little bit more plus, or you take away some minus. Now let's see this small video which shows what it looks like from the patient's point of view.
Let's see the same sequence from the patient's view.
Which is better now, 3 or 4? 3 or 4? 3.
So the patient says 3 is better. So now that power is given, and again the flip positions are tried.
They're about the same. 5 or 6?
They're about the same.
Good.
Even when the choices appear equally clear, there are often small differences in distortion between the two. For example, the letters in this choice 5 are slightly elongated vertically, and those in choice 6 widened horizontally. This is unavoidable with ordinary cross-cylinder testing, and the patient must simply be asked to compare the clarity of the letters between the two choices.
So another thing you should remember is to give the patient the choice that he doesn't have to choose one. Otherwise, what happens is the patient thinks, oh, he has to choose either of the flip positions. So he will keep choosing, and that will make your subjective refraction go around in circles. So you should not do that. You must tell the patient, is this position better or the second position better, or are they the same? Then the patient might tell you that, okay, they are about the same. And whenever you do cross cylinder testing and you are adding or decreasing the power of the cylinder, you should remember to add sphere of half the power and opposite sign of the cylinder for every addition of 0.5 cylinder power. So let us assume that you have added minus 0.5 to the cylinder power already in the trial frame. You have already a sphere sitting there. You should add a plus 0.25 to that sphere there when you are doing the cross cylinder testing, if you're going above 0.5 cylinder power, because what happens when you correct the cylinder is that the circle of least diffusion keeps moving away from the retina. So if you don't add the sphere of the opposite power, it will move away and it will cause blurring. So you need to bring that circle of least diffusion back onto the retina. So you have to add a sphere of half the power and opposite sign for every cylinder addition of 0.5. Now, like I said, you always ask clearly whether they are the same or not. And if the patient is consistently choosing one, like flip one is always what he's choosing, he may be just doing it mechanically. So you have to change the order of your presentation. There are two other instruments that can be used for refining axis and power of astigmatism. One is the clock dial, what looks like this. The patient should be fogged and then gradually unfogged till sharpness and darkness is seen. He is asked to identify the clearest clock hour, and the lower part of that clock hour, that is if it is a 2/8 clock hour, then 2 into 30 will give you the axis of the minus cylinder, and that minus cylinder has to be placed in that axis. The astigmatic fan has lines 10 degrees apart. Now the axis of the cylinder that you're going to place should be perpendicular to the clearest line, and then you can keep increasing power till the most prominent line and the line perpendicular to it. So whichever line is most prominent and the line perpendicular to it should be equally clear. That's how you will refine the power with the astigmatic fan. But better than astigmatic fan and astigmatic dial, it's the Jackson's cross cylinder that is universally accepted for refining axis and power of cylinders. Once you have determined the cylindrical power, now you can go back to the sphere and you have to refine the sphere once more. Is it better with a little bit more plus 0.25 or with a little bit more minus 0.25? That you have to check again. And then you do the duochrome. The duochrome test is to refine the sphere and to ensure that the patient is not overcorrected. It is based on the principle of chromatic aberration, that the green wavelength will be focused in front and the red wavelengths will be focused behind the retina in an immetropic eye. So this is what it looks like. They are black letters on a red and green background. You have to ask the patient whether the red letters are better or the green background is better. Now the idea is that if the patient is a myope and he is slightly myopic still, the red will be clearer. If the patient is a myope and you have given him so much correction that you have made him slightly hypermetropic, the green will be clearer. Now, for a myopic patient is what the duochrome is most important in, and you have to leave the patient on red clearer or red and green equally clear. So let me say that there is a -3 in your trial frame. You give him and he says the red is clearer. You give him -3.25 and he says green is clearer. Then you want to leave him on -3. Don't give him the 0.25. If he says both red and green are clearer and his visual acuity is also remaining 6.6 with the 0.25, you can still give him. But always leave your myope on red clearer or red and green equally clear. There is nothing more, more unhappy patient than a myopic patient whom you have left hypermetropic. And if you leave him green clearer, he's going to start using his accommodation to see distance. And that is going to make him extremely unhappy because myopes are not used to using their accommodation and they don't like using their accommodation at all. So leave him red clearer or red and green equally clearer. This is not so important in hypermetropes, and we usually avoid the duochrome if the patient is a hypermetrope. Now the same steps have to be repeated in the left eye. This is about the right eye we did. Now you refine the sphere in the left eye, refine the cylinder, axis, then power, then refine the sphere again and confirm with duochrome. Now you have both the best corrections in both eyes, but you have done it uniocularly and therefore there may be unequal accommodation demand in the two eyes that can result in eye strain. So if you want the most perfect refraction, you have to do the step called binocular balancing also. If you have a very old patient with no accommodation, pseudo fakes, you can avoid this. And only you do it only if the patient has very good visual acuity, like 6/9 or better. There are two methods of doing this. One is called the Borish method, in which you dissociate the two eyes with three diopter prisms. You use the prism base up in one eye and base down in one eye. Now, if you isolate the line on the Snellen chart, the patient will see two charts, one on top of the other. You fog with plus to 612 and then compare the two eyes. If it's not equally blurred, you keep adding plus in the clear eye till both are equally blurred. And then binocularly you reduce the plus. So if you have given a +1, you binocularly reduce it 0.75, 0.5, 0.25 till the visual acuity is 6.6. Let us see a short video of what it looks like to the patient. So now the line is isolated.
Letters, one above the other. The right eye sees the lower line. Both eyes are fogged, and the patient is asked if both lines of letters are equally blurred. If the patient reports the lower line to be clearer, more plus power is dialed in before the right eye until the lines are equally blurred. The 6 prism diopter prism is then removed. The smaller lines are shown binocularly, and sphere is changed binocularly in the minus direction until best vision is reached.
Now, another method of doing this is to fog both eyes with +2, and then you put a minus 0.25 in front of one eye first and in the other eye. You perform alternate occlusion and see if the patient can understand that there is a difference in clarity between the two eyes. If the patient cannot identify, then the patient, that means that the eyes are not balanced. Then you have to either add sphere or subtract sphere the patient till the balance is achieved binocularly. And if the patient can identify the eye where the 0.25 is placed, then the eyes are balanced. The importance of this is that it should not be, binocular balancing should not go beyond 0.5 or 0.25, 0.5 difference only will be there with binocular balancing, not more than that. Now, next step is to do near add. So if it's in the presbyopic age group above 40 years in our country, presbyopia sets in later in temperate climates. So if you're practicing in the UK, you need to give presbyopic correction only at around 45. And it's based on age and it is based on the amplitude of accommodation. I think a small part of it was already covered by Dr. Chandrasekhar, but the rough estimate we know up to 45 years, it is +1 to, it's +1.5. And when it becomes 50, 2 and so on. This is the RAF rule that is used to measure the amplitude of accommodation, the near point of accommodation, near point of convergence. It's a bar with a box which has various targets on all 4 sides. The box can be slided over the bar and the bar is measured, one side in centimeters, one side in inches, one side in diopters, and the 4th side shows the corresponding age. To determine near point of accommodation, a sliding target with 6/9 letters is moved and it is the closest point at which the patient can see clearly. And for near point of convergence, it is a line that becomes blurred. The side marked in diopters will actually indicate the amplitude of accommodation in diopters, and the 3rd side will show the age. Normal value of near point of accommodation as age advances. At 20 years, it is 8 centimeters, but at 50 years, it recedes to 46 centimeters. So like sir said, you determine the amplitude of accommodation, you leave half in reserve, and then you give the reading addition. Let's see practically how that is done. First step is to adjust your IPD of the trial frame for near vision. So you've kept it for distance. You need to bring it a few millimeters closer for near vision. So adjust the IPD there. Place the appropriate reading ad over the full distance correction and ask him to read the N6 line and at arms. And the important tip is that if you make him read at arm's length and then closer to face also, you can see the range at which he can read. So if you have overcorrected him, he will not have adequate distance range. So if he says that it becomes completely blurred as soon as he takes it a little further away, then you have definitely overcorrected him. So that you should see that he has adequate distance range so that he can see things on the table as well and not just what he's reading. Near addition can be done binocularly, only difference being one eye aphakia or pseudophakia. The last step before we stop is muscle balance. Once you have done your binocular visual acuity, you do a cover test for tropias and use a Maddox rod for any phoria. And if there is a phoria, you need to measure it in prism diopters using the Maddox rod. And for any refractive error that is more than 5 diopters, you need to measure the back vertex distance that can be read off from the side of the trial frame in some trial frames, or you must use a scale. That is the distance from the back of the lens in the trial frame to the front of the cornea. That should be written for high refractive errors because the effective power of a lens is determined by the distance of the lens from the cornea. The further away it goes, if it is a plus lens, the effective power will increase. The further closer it comes, if it is a minus lens, the effective power will increase. So the optician who is dispensing it should know this. So you need to write the back vertex distance. So that is the end point of your refraction, and all the steps have been covered. There are some special situations. Always do a cycloplegic refraction in children and young adults because they have a very active accommodation. In hyperopes, you do a cycloplegic refraction when they are young. In first refraction in myopes, because of spasm of accommodation, they can be pseudomyopia. So you need to see that they are actual myopes before you give them their first glasses. You need to do cycloplegic refraction. Patients who are having intermittent blurring or asthenopia, again, do a cycloplegic refraction before you give them the glasses. In the presence of esotropia and hypermetropia, give a full cycloplegic correction. I think probably Sir will cover it in detail in special situations. So we will leave that. And to summarize the steps of subjective refraction, refine your sphere, refine cylinder axis, and then the power using a cross cylinder, refine sphere once more, confirm with duochrome that you have not overcorrected, repeat the same in the other eye, do a binocular balancing if your patient has very good vision and is a young patient, near ad is given if the patient is presbyopic, check muscle balance, see that there are no severe phorias, measure back vertex distance if it is required. Simple tips, be familiar with your trial set so that you know where each thing is sitting. Don't just sit and fumble there when you're doing the refraction. Introduce yourself and make the patient relaxed. Give clear instructions and alert the patient when you're placing a new lens. Be systematic and follow the plan. Be confident and be patient with your patients, and you will have a set of very happy patients at the end of your refraction. Thank you all very much for this opportunity, and hope to take questions at the end of the session.